Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast. Today, my name is Terry Fletcher. So today we have a little bit of a spin. I was actually going to talk about something else that I mentioned last week about medical assistance, and that is going to come up. But I want to give you the information that came out on the Medicare professional fee schedule. So that's the physician fee schedule. And it was just published, the final rule. Now you still have until December 9th to comment on it, because there's some things in there that you definitely want to make sure that your voice is heard if you're a stakeholder. And so you can really look this up anywhere. You can Google it and make sure that and go to the CMS site and make sure you comment on it if you need to. But I wanted to give you the top things that have been released, just so you're not blindsided and you can see what's coming up for 2022. These are 12 takeaways. There is a reference authoritative site that I follow called Becker's Health, and they're very good about pulling things out. We've got over 6,000 pages to read between the outpatient prospective payment system rule and then the physician fee schedule rule, and then there's a home health prospective pay system rule. So here are the takeaways. So number one, CMS is increasing outpatient payment rates by 2%, and this is the facility outpatient, that's the OPPS, for 2022, and this is for hospitals that meet applicable quality reporting measurements. So they have to make sure that they're doing their QPP information. CMS is modifying the hospital price transparency regulation. Now here's something interesting. So let me give you a little bit of background. So hospitals are supposed to show people or tell people and list everyone, the consumers, how much they charge for testing supplies, their facility fees, etc. And if they don't do it right now, they get fined between $100 and $300 a day. Well, hundreds of hospitals have decided they're better with the penalty and paying that instead of actually being transparent and putting it out there. So this is what's changed beginning January 1st. Hospitals with 3 or fewer beds that aren't in compliance with the regulation will face a minimum penalty of $300 a day. Hospitals with more than 30 beds will face a minimum penalty of $10 per day. With more than 30 beds, $10 per day. The maximum penalty will be capped at $5,500 per day. A full year of noncompliance with the transparency regulation would result in a maximum penalty of about $2 million per hospital. So this is kind of an interesting, I don't know what you call it, just an update. I'm going to check on that $10 per day because I just saw that and I'm like, wait, maybe that should be $1,000, but wait, hold on. No, I just checked it. It said 10. Well, that doesn't help. But maximum at $5,500. So it'll be interesting. Minimum 10, maximum 55. It'll be interesting how they slide that scale when it comes to the penalty. CMS is requiring that a machine-readable file that includes hospital prices be accessible to automated searches and also direct downloads. So you should be able to, on a certain hospital or facility website, be able to say, or Google it, and be able to say, okay, how much will my stay be if I have to go have gallbladder surgery? Now, it may not affect you. I was actually having a discussion with somebody about this on LinkedIn, where let's say that you were asked, or you need to have an MRI, and let's say the hospital charges $1,000, but the diagnostic imaging center next to your house charges $300, but your insurance company is a provider of the hospital, and your out of pocket's $50. If you go to the hospital and have it done, but your out of pocket is 50%, so $150 if you go to the imaging center down the street. Where are you going? Exactly. Most of you are going to say, well, I'm going to go to the hospital because I only care about my out of pocket. I don't care about what the actual retail price is. And that's where there's a little bit of a kind of a, I don't want to say misperception, but kind of a disconnect in the transparency. And the whole point of it was because people were saying in the government that consumers want to have a choice of where they go based on cost. We want to have a choice of where we go based on out of pocket. There's a difference. So cost versus coverage versus out of pocket, that's a big difference. And I don't think anybody's getting that concept. So hopefully they'll figure it out. Number 4 is the final rule halts elimination of the inpatient only list and adds back most of the services that were removed from the list in 2021. So this kind of, I don't know if I like this or not. So in the Trump administration, they had an elimination list for inpatient only. So the certain services like colon resections and some spine surgeries and things that were inpatient only could be done in an ASC. And it was very helpful when certain ASCs, because we're still in a public health emergency, were able to act as hospitals and, have certain services performed. And it's also much more cost effective to the patient as far as an out-of-pocket, but also more convenient. Going to an ambulatory surgery center versus a hospital is so much better. But there was not a concern, but I guess there wasn't enough due diligence on the safety of having certain services and procedures being done in an ASC versus a hospital situation. So that's something that they're going to study a little bit more before they allow that to happen. Number 5 under the OPPS would be CMS will continue paying hospitals 22.5% less than the average sales price for certain drugs and biologicals purchased through the 340B program. So if you're an inpatient, or I should say if you're an outpatient facility, you should know what that means. So now when we get into the physician fee schedule. So this should be anticipated, but nobody's excited about it. Right now, our conversion factor on our fee schedule, so the multiplier we use to times our RVUs of a code. So if a code says that it's a certain CPT code has like a 3.4 value to it, relative value unit, we multiply that by 34.89 on the professional side, and whatever that is, that's the allowable of what we get paid on the Medicare side for professional services. Well, we were supposed to be down around 32 because of the Budget Neutrality Act, but because of the public health emergency, it was increased. Well, they say it was increased 3.75%, but if you actually look at it from last year, which was over 36, they actually doubled that and increased it 7.5%. Well, here's the problem. Now they're going to, again, take off that temporary payment boost of that 3.75% from the Consolidated Appropriations Act because it expires in 2022. And now our reimbursement's going to go down, our conversion factor, from 34.89 to 33.59. And so be aware of that. I know that everybody's trying to lobby Congress, especially MGMA, to get that to go another year where they're not lowering that reimbursement multiplier, but I doubt that's going to happen. It's a Budget Neutrality Act, and it literally takes an act of Congress to change it, and it doesn't seem like that's their focus right now. Now CMS, everybody's saying, oh, after the PHE ends, that telehealth as we know it now under the public health emergency is going to stay. Not so much. So now it says in the fee schedule, they are expanding it, and they are going to amend the definition of interactive telecommunication systems for telehealth to include audio-only technology used to diagnose, evaluate, or treat mental health disorders, and only in certain cases. And so they clarify that mental health services could include treatment of substance abuse disorders such as opioids. It's also going to focus on rural health. And so, like I've mentioned for the last 18 months, our current telehealth under the PHE that was extended, by the way, until January 2021 or 22, that is not going to continue at some point. Now, I am actually thinking that they're going to probably say, okay, January's enough is enough, because this is just what I'm thinking. I know that they may get some pressure to extend it through 2022, as I've heard, but it just doesn't make sense anymore because we're actually seeing such a downward spiral, which is great on hospital admissions and COVID-related deaths. Number 8, under the physician fee schedule, the final rule will nearly double Medicare Part B payment rates for certain vaccines, including the flu vaccine, pneumonia, and hepatitis B. And they hope that the increase in payment rates from $17 to $30 will not only improve access, but have greater vaccination uptake for an immunization for practices that now want to have that as part of a service in their office. Number 9, CMS is updating the clinical labor rates that are used to calculate practice oh my goodness, practice expense under the physician fee schedule for the first time in 20 years. So as a result, payments to primary care specialists that involve more than one clinical hour, such as geriatrics and family practice, they may increase a little bit. So they haven't done that before based on specialty. They've only done it based on code. So it'll be interesting to see how that adjusts based on certain services and based on their reported specialty as they have on their taxonomy code. So moving over to home health prospective payment system, Medicare home health reimbursement rates will increase 2.6%, or they're going to have in the pot of money there $465 million in 2022. Now remember what home health reimbursement rates are. Those are home health agencies that provide services to patients that qualify for home health. So it's not a physician that makes a house call or a mid-level provider that does that. These are actually home health value-based services. And number 11 is the final rule expands the home health value-based purchasing model, and with the first performance year beginning January 1st, 2023. And so they're going to adjust the fee-for-service payments to certified home health agencies on the quality of care provided during the 2023 performance year, and they will collect that in the 2025. The home health hasn't been able to participate in quality measures before, and now they're going to be mandated to. And the final one here for home health payment system would be the final rule implements provisions of Consolidated Appropriations Act that establish survey and enforcement requirements for hospice programs that serve Medicare beneficiaries. So I'm sure you've heard in the news what a mess it's been. And so, as far as the deaths and just mishandling, and so they're basically saying they've revamped the hospice and a lot of the skilled nursing facilities to make sure that patients are well taken care of, and they're above reproach because it just wasn't good. So the COVID pandemic really shed a light on a lot of these situations, and so I think I'm not saying it's a good thing, but if you have to look at a silver lining on something, that is definitely something that became an issue. Okay, so I also wanted to mention a couple of top coding issues that have resulted in claim denials. There was a survey done recently by a management consulting firm that Medicare used, and they also analyzed over 100 billion worth of denials and claims for a collective amount of commercial plans. And there was 2.5 billion in audited claims. So let's take a look at that. But first, let's thank Medisoft Cloud for their sponsorship today. And they are a cloud-based medical billing system and a fast and highly scalable platform that transforms the way healthcare providers manage revenue cycle management. To try Medisoft Cloud, call Microwise at 800-955-0321 or visit medisoft247.com. Okay, so what we want to look at is the top reasons for denials related to coding issues. So number one is health insurer deems the information submitted by a provider does not support the level of service billed. Okay, so basically they ask for records to see why you billed a level 5 and it's not supported. That's typical. Number two, the procedure code is inconsistent with the modifier used or required modifiers missing. That happens a lot. And then the last three all are related to ICD-10 codes. So number three is the diagnosis is invalid for the date or dates of service documented. Because we're in a fiscal year for I-10, so October 1st through September 30th, I have noticed that a lot of people do not update in the last quarter of the year their ICD-10 codes when it's not a calendar year like CPT. So make sure you are doing that. Number four, the diagnosis is inconsistent with the procedure. So billing, let's say, an ankle fracture diagnosis for a EKG service, and you'd have a cardiology situation. Or the diagnosis was not covered. So make sure you are reading your national coverage determinations, your LCDs, local coverage determinations, to find out exactly what the coverage policies are before you submit a claim. Otherwise, you're spinning your wheels and you're going to get a denial. So our coding question today is a little different. It is something that I haven't dealt with in a long time, but I get this question every once in a while, and it is about billing for counseling. And it's a code that is 90832. Medicare reimbursement rates are about 71. Medicaid actually pays for it at around 59. But what is this code specifically? So it is a therapy code, and it is a 30-minute code but who can actually bill for this code is really something you want to take kind of a look at, the definitive service, if you will. So in 90832, this is a definitive service for therapy, but my question that I was asked was, can one of our clinicians bill for it? I want to hire a professional counselor. And I said, well, unfortunately, no. So license level requirements for psychotherapy sessions, which is what it is. And again, it's time, 30 minutes. It has to be either a clinical social worker, a marriage family therapist, a clinical psychologist, so a PSYD or PhD, or a psychiatrist, which is an MD. And if it is any of the former before the psychologist, they would have to be working with a supervising and referring physician. And the patient also has to have a mental health disorder. So it is a mental health or behavioral health code, basically therapy, that would have to be reported that way. So what they were asking is they want to hire a professional counselor they have a counseling certification, but they are not a clinical, if you will, therapist. And so the answer is no, you cannot use that code or any code to bill for that service. I'm getting a lot of questions lately about, they call it lifetime care or lifestyle care. And you have to really, do your due diligence, because not everything is considered to be medically indicated or a covered service. So before you try to, get out and start billing or coding for something, make sure you know if it is a covered service. Okay, so I wanted to call out a couple people today just because I've had some great emails and just some really nice comments and some follow-up from people. So first of all, I want to congratulate Lourdes. Lourdes just got her CPCA, and she is an avid listener. Thank you to Brianna P., Ani M., Carol H., and Amy Waller. Thank you so much for just the really kind DMs that you sent me on LinkedIn and just some of the positives. And a special thank you to Brenda Knapp. Brenda, I can't even tell you how much that really sweet email meant to me. So just letting me know that you appreciate that the Codecast and it inspires you to keep going. So I hope everyone does continue to appreciate the information. We work hard to make sure that we give you timely information and hopefully what you really, need to do well in your job, and hopefully, continue to grow in your job. I'm going to go back to a lot of coding, and I'm going to start doing some coding questions and a little bit more with coding than regulation. I know I've kind of started to sway towards regulation just because I'm always getting the questions for that. But I am going to get back quite a bit to coding, as you'll see coming up soon. So a couple of things. I'm going to start with cardiology, since that's my number one specialty. Get into a little of the peripheral vascular services, which is non-coronary. We'll throw in some orthopedics, some derm, some wound care, obviously some E&M. We'll get into some rheumatology, some what else do I want to talk about? We're kind of, all over the place when it comes to our specialties. So we'll do the best we can to hopefully pick up as many specialties as we can, maybe some pulmonary, some general surgery, some OB-GYN, but answer some, bring you some questions and answers that can hopefully really help you. And then we'll transfer it to a blog on my site where you find articles and everything, so that you can actually read the question and answers and hopefully use the information from an authoritative reference, because we try to always give you where we got that information as well. So you'll find that in the future. You'll see that starting on my top 10 Tuesday in this month in November. So hopefully that'll be helpful. So next week, I am going to try to get to what a medical assistant can and can't do. Like I mentioned before, I had done a 4-minute segment with Talk 10 Tuesday for ICD-10 Monitor. Huge following for that. So it definitely blew up. It's been getting some traction with some different entities that picked up my article as well on ICD10monitor.com. So I'm going to comment on that next week. So everyone, let me just kind of back up a little bit. I always forget. Whenever I forget to do a personal tidbit, I do get letters. They're like, wait, you forgot to tell us something about your personal stuff. I'm like, okay. So as you know, I'm planning a wedding for my daughter, and we have her wedding gown came in and her veil came in. And now we are planning for her bachelor party, which is in January. We got the venue signed. So she's doing it at a brewery in Phoenix, Arizona. And so we're pretty excited about how things are kind of shaping up for everything. And now mom has to find something to wear. So I'm not excited about that. So we'll see. It's in March. So hopefully it won't be too hot in Arizona where she's getting married. But shout out to Summer. We're very excited for the process. And even though it's stressful planning a wedding, when you do it for your only daughter, it is fun. So mom's having a good time. I'm actually enjoying it. So, and luckily it's 5 months away. So I'm not too nervous yet. So we'll see what happens. Also, go Steelers. We've run 3 in a row. I'm so happy. And we're now at 4-3. So hopefully we'll step it up. Where next time is Monday Night Football. So I hope you're watching and also listening to me on the WTF podcast on Steel City Underground. I do it every week and it usually drops on Tuesday or Wednesday. So make sure you check that out. And it's What the Football. So everyone, again, make it a great day. Make it a great rest of your week. And thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.